So basically, Everett, first, I'd like to thank you for providing the impactful or very important new knowledge to the melanoma community by providing the evidence supporting the use of anti-PD-1 monotherapy and pembrolizumab specific, regardless of the BRAF mutation status and the prior use of MAP kinase inhibitor combination. So I'm wondering, as for the first line choice for BRAF mutant patients, what would you prefer in terms of anti-PD-1 monotherapy versus MAP kinase pathway inhibitor combination?
So I think it's an excellent question, and the choice for me is actually immunotherapy. You alluded to monotherapy. I would actually point you to the Checkmate 067 trial, by Dr. Wolchok and others, where actually at 5 years they had a survival of 52%. It was randomized between nivolumab, ipilimumab, and ipilimumab, with the arms of nivolumab and ipilimumab not being planned to be compared directly. However, when you look at their nivolumab, single arm, survival at 5 years was about 44%, which is very similar to what we achieved, here in this article, when, with retrospective analysis of the KEYNOTE, 001, 002, 006. But when they combined the ipilimumab with nivolumab, the survival was 52%, so nominally higher, although statistically one should not compare them. And when they published the last update, they also looked by the BRAF mutation status, and for the BRAF mutant patients, the survival was actually even higher nominally, again, not pre-planned analysis, but 60%. And that actually tells me that probably the combination of ipilimumab and nivolumab, in my mind, is the best combination for patients with the unresectable stage 3 or stage 4 melanoma in terms of survival. And thinking about it, there are some interesting results from other trials for the patients with BRAF mutation, especially with ipilimumab. The trial we published and presented, the randomized trial of ipilimumab and talimogene laherparepvec, the TVEC, Imlygic, the oncolytic virus. When we looked by the BRAF mutation, strikingly, again, better results were obtained with ipilimumab alone or with TVEC in the BRAF mutant patients. So there is something actually about ipilimumab and its ability to treat and provide long-term survival to patients with BRAF mutation. BRAF wild type, it needs probably a partnership, but for the BRAF mutant, ipilimumab actually adds a big delta, in terms of survival. So, when I treat patients with the BRAF mutation, if they are otherwise robust, they do not have severe comorbidities, no severe autoimmune disease, no transplant, good performance status, no severe cardiac issues, I actually tend to come with ipilimumab, nivolumab these days as a frontline therapy for those patients.
Actually, there is a sign or a kind of concern over the safety of the ipilimumab or nivolumab combination therapy. By saying that, I mean people always refer it as synergistic in terms of immuno-related toxicity, but additive in terms of the efficacy. What do you think about that?
That is an interesting question. Unfortunately, we haven't tested it yet fully. It will get tested, I think, in those several, trials like the switch trial where, people start with either targeted therapy or ipilimumab, nivolumab, vice versa. or actually use the encorafenib, binimetinib as a run-in, kind of a treatment to get patients optimized and then start ipilimumab, nivolumab. The data from Hody, and his group published in Science Translation a couple of years ago suggested that actually ipilimumab and like anti-CTLA-4 therapy, tends to require expression of MHC class 1 on the tumor cells to be effective, and complementary, the PD-1 actually require HLA-DR, which is, from our work at Vanderbilt and others, class 2. So that could be true. Whether it's additive or synergistic, it is really an important question. What you would need is a long-term, survival of patients who were treated with a sequential therapy versus the combined therapy to realize whether you need a toxicity or not. The one thing about ipilimumab, unlike the anti-PD-1 therapies, it is actually a dose response drug. Clearly from the Italian group by Paolo Ascierto, the 10 milligram per kilogram provided long-term survival to over 30% of patients, while 3 milligrams per kilogram to actually 22% of patients, which is kind of reproduced from the Hody data, the initial paper. Yeah, you're right. Is it synergistic? Is it additive? I think the real issue is whether by using the combination from day one, you may save somebody who will not make it to the salvage therapy by a CTLA-4 antibody. So somebody who actually would otherwise die on monotherapy before they can be salvaged, where you can actually salvage them with combination, because that's the real proof. That's the real question. Are you saving somebody who you cannot who cannot be saved later with the sequence? In terms of toxicity, I actually part of my career is spent in toxicity management of drugs, as a drug developer. And I think it's very important to manage and understand toxicities, kind of manage the downside of the drug by, that improves the delta for the patient, whether it's a targeted agent like VEGF or, or whether it is immunotherapy. The retrospective analysis of databases, when you look at the mortality from anti-PD-1 or the combination or the CTLA-4, suggest that there is an increased mortality, but it's not really excessive. The long-term mortality for either Pembrolizumab alone or nivolumab alone was 0.4%. While for the single agent CTLA-4, probably driven by the 10 milligram per kilogram dose, which was used, for adjuvant therapy, was actually 1%. And for the combination ipilimumab, nivolumab is 1.2%. So it is higher, but at the same time, it's about 0.8% difference. So if the 5-year survival data suggests that there is a difference about 8-10%, you can distract that, and that's actually with the mortality already in it, that's already, the mortality is in it. Obviously, people now try lower doses of ipilimumab, see if it's better. And what you alluded to is a question whether one should start with anti-PD-1. Our 10-year analysis and follow-up from Pembrolizumab, we published in JAMA Oncology, suggests that the survival was about 40%, regardless of the BRAF. Of course, if you use BRAF first, some of the patient selection plays a role, but overall I would place it around 40%. And then the question is whether you should even come with ipilimumab at a salvage dose, which may be even higher than 3 milligrams per kilogram, suggested by the Paolo Ascierto's data. There is a lot of ongoing trials which use ipilimumab, nivolumab, or ipilimumab, pembrolizumab after anti-PD-1 progression. Good example is the recent update of the small phase 2 trial Pembrolizumab frontline, followed by ipilimumab 1 milligram per kilogram plus pembrolizumab from Thomas Gajewski group at the University of Chicago, suggesting actually long-term responses in about 28% of patients, so that's actually 27%. So that actually is a really remarkable second-line efficacy from two drugs we already know how to use. Melanoma certainly went a long way, and in last 10 years, we collectively improve survival and quality of life of those patients. Remember, 10 years ago, melanoma was like pancreatic cancer, survival less than 1 year for median, and 2 years survival about 5% or less. This is not true anymore. And in the recent American Cancer Society update on cancer treatment in the United States, the cancer type with the most improved survival was melanoma, followed by non-small cell lung cancer, again driven by immunotherapy, coming from the trials, you have participated in as well. And we all did, since 2008, phase 1 in nivolumab, and then, pembrolizumab started, very soon after that in 2010. So this was a really remarkable decade for melanoma research and for melanoma patients.
So basically, in terms of the first-line choice, would you think about the tumor growth tempo or even the tumor burden when choosing, ipi-nivo over, MAP kinase pathway inhibitor combination?
Yeah, no, it's an excellent question. We are all struggling with that, and you spent 3 years with Keith Flaherty, so you are familiar, with the data just thinking about the BRAF mutant, melanoma, subgroup, the 45% roughly of melanoma patients. They, of course, as you are familiar, they come in 2 different subgroups, BRAF mutation, there are 2 subgroups. One, where really the immunotherapy still plays a big role. Those patients may have a lower tumor burden, and on molecular characteristics, they will have well-differentiated cells. They will have a nicely expressed BRAF mutation and staining by immunohistochemistry. They will have a MITF high expression, meaning like these are differentiated cells. And the AXL, which is one of the tyrosine kinases expressed in a primitive, stem cell-like, cells, will be low. Those patients actually, looking at some retrospective data we published in Journal of Immunotherapy in Cancer with Douglas Johnson and others a couple of years ago, suggest that whether you start with immunotherapy or targeted therapy, you will achieve long-term survival. We actually know that with targeted therapy, and encorafenib, binimetinib being probably the latest and best well-done example, the Columbus study, 34% at 5 years. So that's it's there, and when you have a low tumor burden, low LDH, less than 3 sites of disease, good performance status, the pills will actually do it, and most likely, as you are aware, through its effect on the immune system. Once you treat patients with the BRAF-MEK combination, you actually see the influx of CD8 killer cells into the tumors, and when they become resistant, half of those tumors will actually be what we call empty, the infiltrate will be gone. That's the Roger Lowe paper in Cell with Tony Ribas, Jeff Sussman, and Doug Johnson and others, a couple of years ago. And but then there is that other group, which has a spindle-like dedifferentiated cells. The BRAF is kind of low expression, kind of diffuse. There is a AXL, high, and MITF low. These are very primitively looking cells. Those patients, actually, I will start treating with either combination of BRAF and MEK inhibitor, or I may even combine it with anti-PD-1 for a triple, kind of combination, trying to decrease the tumor burden. But as you are aware from that paper in JITC, those patients actually all were dead within 14 months. Their median survival was only 5 months, and they almost resemble biologically colorectal BRAF mutant patients. And as you recall, in colorectal cancer, the breakthrough really came with addition of anti-EGFR inhibition, which was based on the Nature paper in like 2012, 2013, showing that actually the BRAF mutant colorectal cells will be sensitized when you combine the BRAF targeting with EGFR targeting, and we just had approval of combination of encorafenib with cetuximab in those patients with a survival improvement. I have actually talked to Keith Flaherty over the years, that this would be a trial to do because anytime you look at Kaplan-Meier curve in any of those trials we had run over the years, you see those patients 10-15% with very aggressive tumors, some of them BRAF, some of them BRAF wild type, but molecularly they are similar. They are empty tumors, mesenchymal transformation is there, stem cell-like features, and they die on that left side of the curve within 6 months. And very difficult to salvage with no matter what we do. And that's why I think we need actually to think outside of the box for those patients, because they will respond to our treatment. You alluded to starting with BRAF/MEK, and I do that. But I know when I see that patient that no matter what I do, that patient will die within a year. Because, as you recall, there was no tail, the curve just went straight down to zero. So this is a different cancer. In BRAF, we kind of have the molecular characteristics, but so far we are lacking a combination to test in those patients. It will be a difficult trial in a sense. You need a very effective combination, but you can see how you can potentially just have a single arm study, characterize the patients, take the performance status of any type, 1, 2, 3, like really heavily ill patients. And if you have something very active, kind of going back to the old days of PLX4032, vemurafenib, which we did with Keith, and Paul Chapman and others, where you see Lazarus effect, where you really will see those patients improving and with durability, because now we know how to improve them. They will respond, and you have seen it in your practice for 2 months, 3 months, but after that there is a crash and there is nothing you can save them with. And I have tried to combine BRAF/MEK, even I have tried to combine ipilimumab, nivolumab, and then within the 3-week break from ipilimumab, nivolumab, I was giving them 2 weeks of encorafenib, binimetinib, like in between. It didn't work. 6 months, 8 months survival. It almost looks like that the pathway of the MEP kinase pathway and the anti-PD-1 CTLA-4, I think they overlap, in their effect, that there is an interaction there, and that the patients who are not being served right now, they need a different approach, they need a different approach. And if we find out in our melanoma community what that approach is, my prediction is it will be applicable to other tumor types with the similar characteristics, whether it's colorectal cancer, whether it's some of even the differentiated prostate cancers, these stem cell-like empty tumors, there potentially could be a histologically agnostic approval for what we may develop in that specific group in melanoma patients.
Thank you. Actually, Keith and I, and together with Dr. David Fisher, published a review article last year in Nature Review of Clinical Oncology, specifically focusing on that group of, at the cell level. It's not the patient level. We call that persister. In terms of the mesenchymal transaction kind of cells. And we literally develop a conceptual model for that. We call that cell state fluctuation kind of model. And as you just mentioned, Dr. Fisher is super, he's referring that, just as you did, as another kind of cancer. And I'm wondering, as observed before, that in this subgroup of persister cells, there will be activation of, tyrosine kinase receptor. So basically, I'm wondering, although it's just a pure speculative, if, for example, the TAM family, like tyrosine axle as well as CMET, if they were activated, could it be possible that the cabozantinib will work in this way together with like PD-1 or?
No, I think you are absolutely correct. The question is, I think we need to do maybe, like seriously, more science is required, before we go into trials. I would suggest, and Fisher's group is probably the best position to simply interrogate those cells, and see what comes from a wide, cast screens. And I think you are thinking the same way I'm thinking. Actually, XOMER, kind of a targeting, in my mind would be great. The question is, you mentioned cabozantinib. There is always the question whether a more multi-target inhibitor will be better, or whether we need to develop very specific, very highly potent, XOMER inhibitor, and whether, you probably are aware of some of them in development, and some of the side effects, including ocular, actually, toxicity. Whether, these may potentially have problem, because you may target the target, but if the patient becomes blind, that would not be good. And if it's an on-target, toxicity, it's very difficult to engineer out. You can get rid of the off-target by making a better inhibitor, but if your inhibitor is actually on-target, destroying a very important organ like an eyesight, that is a problem. But that I think is important. The other thing, I always go back and take the lesson from vemurafenib development from the PLX4032. As you recall, and probably Keith, talked about it, when we started the first formulation of the drug, the molecule was the same. It was the formulation, it was the solubility, what you actually put there to make it a drug, which was suboptimal. We couldn't get the solubility up. We couldn't get the pharmacokinetic, the levels, high enough for the kill. And we just achieved stable disease stasis. But instead of killing the drug, we actually reformulated it with the help of Roche engineers. And it was now 10 times more soluble, 10 times more potent, and still the same molecule. But all of a sudden, it inhibited the target more than 90%, and that inhibition was required to achieve kill of the cells and the responses. So not only it is important to know the target, but also it is important to develop the right inhibitor, and it is also important to get a little bit lucky that that right inhibitor will not have severe on-target, but in other organs toxicities, because that could be devastated. The AXL may be the right choice, but it may not be at the end, the right choice unless you somehow make it a tissue-selective AXL inhibitor. Tissue-selective AXL inhibitor to avoid the eyes. That actually would be an interesting challenge and an interesting drug development, But first, before any of that, I would actually say that, we need to first really study those exact cells you described, which are really like a different cancer. But at the same time, it can be extremely rewarding because although they are different, they resemble other subgroups of other organ cancers. Actually, very similar cells exist in prostate cancer. At Roswell, we have a very active prostate group. And when you look at the hormone resistant, prostate cells, it is actually amazing how they are de-differentiated, how they look like stem cells, and how they actually change their epigenetic programs. Epigenome targeting may also be of interest, and maybe a program cell death. We have a trial with enzalutamide and BCL2 inhibitor with Dr. Dean Tang, who is the chairman of our pharmacology department and my partner in leading the developmental therapeutics. So we actually combine enzalutamide and BCL2 inhibitor based on his preclinical data, which we published in Nature Communications. Yeah, and another one actually with EZH2 inhibitor for epigenome targeting. But I think we will crack it, you know, like I think in next 5 years we will crack it. It will not be easy. And I think it will be a partnership with a targeted therapy, some immunotherapy. And I would not be surprised if maybe injectable, like oncolytic virus may play some role to actually change the microenvironment in these specific tumors, because it is very prohibitive for immune cells to go there and survive. So maybe oncolytic virus may change that.
As you mentioned before, in terms of the newly approved, the triple combination in terms of BRAF, MEK / PD-1 or PD-L1 inhibition, what do you think about that? Because the survival benefit to me, it doesn't seem to be that overwhelmingly positive.
Completely agree with you. You know, we look at different triple combinations for years now, and even before that, you know, in my practice, I have been using the approach. We were able to actually treat patients with triple combinations. You know, starting, let's say, with dabrafenib, trametinib, and if there was some progression, you know, add in pembrolizumab, you know, was one. And, you know, we kind of knew very soon from the phase 1, you know, studies, phase 1Bs, you know, that it's actually, you know, safe and relatively not very toxic. The study you mentioned, you know, presented at ASCO, you know, published and now leading to approval, actually didn't meet, you know, the overall survival, you know, benefit. There was a progression-free survival improvement, you know, statistically significant, but really by several months only. And you know, just to get the details for the listeners, when the primary endpoint was actually progression-free survival as measured by the investigator, and that was the primary endpoint, and that was the endpoint which was met. However, on every trial, we try to have objective jury of radiologists who do the central reading, you know, and then they kind of adjust the investigator, you know, data. And that happened in this case. And by central reading, the progression-free survival actually was not statistically significant. You know, it was only by the investigator, but that was the primary endpoint. You know, the central reading was not a primary endpoint. So the study met primary endpoint, and by the strict criteria of approving what was agreed at the design of the trial, the approval is correct. But when one looks, you know, how much it will resolve our conundrum, you know, where these triple combinations should be used and for whom, it is still a little bit out. The one thing, you know, as you alluded to, you know, the combination of ipilimumab, nivolumab, or simply sequence, you know, will one be superior to the other? The same goes here. You know, when you think about progression-free survival, you know, I would be thinking progression-free survival of a triple combination versus sequence of either targeted followed by pembrolizumab, or pembrolizumab followed by targeted, like a three-way, you know, kind of a race, you know, would be, because that would actually tell us the value of the triple combination. And, you know, that is still a long way off, and that was not the design of the study. So it is out there, it is an option for the patients, and there are several triple combinations, you know, going through the approval process, you know, the encorafenib, binimetinib, you know, as one, dabrafenib, trametinib, you know, with either pembrolizumab or spartalizumab. And so we will await, you know, like the other triple combination, but this is the first one. And for my own historical benefit, you know, it's I'm glad to see vemurafenib, cobimetinib, you know, achieving some bona fides again. You know, it has been a long time, so I salute, the colleagues who finished the trial, and Levi Garavay is now at Genentech. So I think, he has been involved, with Keith and with the whole melanoma group since the beginning. So I think, for him, it also is a nice achievement coming full circle again with the drugs, he helped develop from the inception. So that's kind of nice to see.
Yeah. As you alluded before, when a patient progressed from the MAP kinase inhibitor combination and you added anti-PD-1 monotherapy on top of that, what does that look? Because it's not normally a first-line setting. It's just like after the progression,
Yeah.
and then use the triple.
So we are lacking prospective data for that approach. This is like a practice, which we can practice like that in the United States. We are still lucky to have access to some moves, which otherwise would not be available. For example, in Europe, in Czechoslovakia, Czech Republic, I'm originally from. That is not something people can do. And I have to confess, I should start collecting some retrospective data, with friends on that approach. But I do have quite a few patients in my practice where they did have actually progression. And once we added, the third drug, they stabilized and they remained stable for a very, very long time. But I am lacking data to cite you, and actually that would be a good retrospective analysis, to simply say, do you have any of these triplicate patients, and can you tell us, what happened? The problem will be a recall bias, because the ones who did well, we still have in practice. The ones who didn't do well, they are not in practice anymore, and it will be hard to find them, like the ones where it didn't work. But I do have, I would say handful, probably about 5-6 patients still in my practice where, it started about 2017, 2016, and they are still on it. And it's really difficult to stop any of the drugs, because remember, you started the 2 and then the 1, or 1 and then the 2. And I always come to the point of thinking, can I stop any of that? And I'm not sure. And because nobody is telling us to stop, so we continue. So I have a patient cycle 68 of pembrolizumab, with dabrafenib and trametinib and everything together. And she's very happy. She has very few side effects, and cancer is gone. She's in complete response. And I still don't know what I can stop. And I talk to her about stopping something, and she doesn't want to stop anything. So we keep going. And she's happy because she's alive now. God, like, what is it? 6 times 3. 180, it's like 200. Yeah, it's like 4 years, she's alive, she's very happy. And I think the longest patient I have, actually not on triple combination, but on just pembrolizumab, was a patient who was enrolled on the, like the expanded access pembrolizumab, in 2014. And he's, from, Indiana, from other state. I was at Vanderbilt at the time, and we still keep in touch. And this is now 6 years later, and he's 88. And I always tell him, you can stop that pembrolizumab, and he doesn't want to stop that pembrolizumab. So he's getting pembrolizumab for 6 years. And he does have some arthritis. But he's also 88, so that may be age.
Wow.
And he plays golf, and he's very happy. And he goes every 3 weeks to his doctor, gets pembrolizumab, and insurance, covers it. And again, we are waiting for the data when we can actually stop, safely the anti-PD-1, and more data is accumulating that you can. But there's still a small subgroup, who kind of don't do well and cannot be salvaged. And until we have randomized prospective data, it is hard to know if it was the stopping of the anti-PD-1 or if it's simply the biology of the tumor, which led to the resistance, and ultimate progression. But, this gentleman is 6 years on pembrolizumab and doing great and doesn't want to stop it. It's a revolution, and immunology came through melanoma to cancer. Of course, melanoma, renal cancer, and non-small cell lung cancer. That was it and change how we treat it. And we now understand that even chemotherapy and targeted agents like the BRAF MEK inhibitors, they actually activate the tumor microenvironment. They actually work through the immunotherapy. As you know, when you take vemurafenib and take cells and put them in a petri dish and put vemurafenib on them, they will enter slow cycle. Very few of them will die. But if you do the same thing in a live patient, half of the tumor will die very quickly because of the influx of the immune CD8 effector cells. And that happens because the immune system is there. So, although targeting the BRAF, targeted therapy, but it's actually the immune system which is doing half of the work of killing of the tumor. So, and now we understand that chemotherapy does the same thing. And that's why it's now a standard of care in lung cancer. The combination lung cancer is actually chemo plus, pembrolizumab, nivolumab, but the chemotherapy plays important role there to actually sensitize and weaken, the defenses of the tumor to be then more visible to the immune system. And I think we will have a really good time, teasing out, the other subgroups. And, absolutely, I'm looking forward, whoever can break that barrier of those resistor cells, those mesenchymal cells, that will be a big news. And really, I think it will add, not just in melanoma, but across tumor types, it will add good 10% improvement, across the board, I really think so, and it will be interesting to see, which combination will it be? Will it be the AXL? Will it be something else? But I think it's within our reach within next 5 years to actually have it pretty much figured out. That will be interesting thing. Yeah, very
Thank
good.
you so much, Dr. Puzanov. And big congratulations again on your JAMA Oncology paper.
Thank you very much. It has been a real pleasure to lead that group, which is really like outstanding group of who is who in immunotherapy and melanoma research. It's been a real honor to be selected and as a lead author and finish that work and show that, after 10 years, pembrolizumab and in general the checkpoint inhibitors, PD-1, actually made such a big difference in lives of patients and improved their survival and quality of life as well, with low side effects. Thank you very much for having me.